much, Mr. Chairman, ladies and gentlemen. Asymptomatic aortic stenosis is a subgroup of the guidelines on valvular heart disease. And of course, there's always a little bit controversial what you should do with patients where you see a very calcified, heavily calcified aortic valve that fulfills all the criteria for severe stenosis, but those patients that present to you are asymptomatic. And then always the question comes up, what is asymptomatic and why was he referred to a cardiologist? Why did he came to the attention of a surgeon or a cardiologist? So first, the asymptomatic aortic stenosis. So what is the patient population actually that we're talking about? So from all the patients that present with severe aortic stenosis, about 25% of these patients are asymptomatic, about 75% of them are symptomatic. So for the last category, it's clear that we should probably operate upon them or perhaps now do a TAVI implantation. From the asymptomatic ones, there's always some doubt whether they're really asymptomatic. And these patients, you can perform a stress exercise test. And then it turns out that about 6 to 10% of these patients are indeed symptomatic when you exercise them. Only when they are in rest, they think that they don't have any symptoms. And the exercise test is negative in roughly about 15 to 90% of the patients. So actually, if you look at the total number of patients with aortic stenosis, that's quite a large number of patients that have a severe stenosis that don't need treatment up until so far. So what do we know about asymptomatic patients? Well, it's not always a benign disease. There's a kind of risk for those patients, and the risk is about 0.5 to 3% per year of a sudden death. And then, of course, it may also occur during follow-up. And what may happen, of course, with these patients, they may become symptomatic and then they need to be operated. So as you can see here from a study in Circulation in 2005, the survival free of symptoms, actually after 10 years, is only 20%. So either these patients die or they will be operated during the course of follow-up. So can we then compare groups of patients that are operated early on and patients there where you defer surgery? So the number of cardiac deaths in patients that presented who were asymptomatic, you see that those ones who had early surgery, some of them died due to congestive heart failure, 3.4%. But those that didn't have surgery, the percentage was 13%. Myocardial infarction 2.8 versus 4.8. Sudden deaths 1.7 versus 4.1. So what you can see here is that actually a lot of these patients, they experience cardiac-related symptoms or complications. Then always comes the question, of course, well, but if you wait, patients may also die of another disease. And so if you operate on them too early, you may do that while it's not really necessary because another disease may appear where they die from. So the non-cardiac death in these two groups, the ones who operated, cancer was the death, of course, in 4%. And in the patients who were not operated, it was 10%. And of course, those patients who were not operated, they were also followed for the same amount of time. Stroke 2.6 versus 5.2. So you see much more actually other diseases that appeared in the non-surgical patient population. And of course, it's an observational study. It's not a randomized trial where you randomize patients between surgery and watchful waiting. These are just observations. But it's interesting that a lot of these patients that don't get operated also may die of cardiac disease. So, what are predictors then of adverse outcome? Can we learn something from there? Well, predictors of symptoms that develop and adverse outcomes are older age, presence of atherosclerotic risk factors, and of course we can learn a lot from echocardiography. First, valve calcification, peak aortic jet velocity, left ventricular ejection fraction, where that is lower than 60, rate of hemodynamic progression, increasing gradient with exercise, excessive left ventricular hypertrophy, and abnormal tissue Doppler parameters. And all these ones are in the guidelines. So if you have patients who are asymptomatic, watch to these factors whether they will progress to a more severe and a symptomatic aortic status. Then, of course, you can do exercise testing, and then you can see whether patients become symptomatic during the exercise. And you have to look then for also abnormal blood pressure response and whether they develop symptoms or ischemia on their EKG. So one of the last remarks here is that you can also look at the biomarkers. We don't know exactly how to interpret them. I mean, we know that once they are elevated, that's a bad sign. But exactly what the cutoff points are and when you have to start treating them is not clear yet. So we want to look at adverse outcomes. 2% to 4% of the elderly patient population have this disease. And it's highly mortality when a patient has a severe stenosis and once he becomes symptomatic. And that is always, in this classical curve, it's displayed very well. When patients are asymptomatic, their survival is quite good. It's only a small percentage, 0.5 to 2 to 3% that have sudden death. But once you become symptomatic, your prognosis is actually quite dismal, as you can see here. But we also have to realize that this curve was just drawn by hand. It's not really based on data. It's made by Brownwald, and he said, I think that the prognosis is very bad once you develop symptoms and you have a severe stenosis. Left ventricular hypertrophy is something we want to avoid, because in a lot of these patients, it's very common, and up to 90% with stenosis, they have left ventricular hypertrophy. It is an independent predictor of mortality. So actually, you want to avoid that patients develop it. And then it also persists in a large number of patients, even after surgery. So left ventricular mass regression is not always optimal. And in some of these patients, especially the elder ones, it also progresses to a myocardial fibrosis. So your left ventricle will never go back to a normal state. So it very much correlates also with the symptomatic status. So asymptomatics, 48% with them have a high left ventricular mass. So you can already see that, they will progress to a symptomatic status. So the question is always, should we then perform surgical AVR early, before left ventricular hypertrophy is irreversible? Because it may lead to a better left ventricular remodeling, and it may also prevent some conduction disturbances. And then ultimately, it may also improve quality of life. Because if you wait too long, patients will become symptomatic, the quality of life will go down, and then you start operating on them. So if they need the operation anyhow, why wait so long? And actually, this article just appeared in the Journal of Thoracic and Cardiovascular Surgery from the group of Cleveland Clinics, and they looked at patients who were asymptomatic. And what they conclude here, if you can read that, severe left ventricular hypertrophy with left atrial dilatation can develop from severe aortic stenosis even without symptoms. These changes can persist, are associated with a decreased long-term survival even after successful aortic valve replacement. So you will never get them back to the normal life expectancy of the normal population, and could be indications for early aortic valve replacement if supported by findings from an appropriate prospective study. So actually, this article points to the fact that we don't really know what we should do with asymptomatic patients, and that we should try to conduct a prospective study. So what we would try to do with asymptomatic patients, we want to prevent sudden death, but there are no trials, but only prospective studies. And prospective studies, and there's another cohort study, shows that once you have operated patients, with the line there with the OP, and the conservative patients, that you see there's a difference in survival. But of course, it's always a drawback. How can you compare these groups? Why did you wait in a certain group much longer than in the other group? And why did you operate on these other patients much earlier? But at least what we can read from the conclusion, early surgery is there for a therapeutic option to further improve clinical outcomes in asymptomatic patients with very severe aortic stenosis and low operative risk. And of course, you always have to take the risk of surgery into account there. Now, what do the guidelines tell us for the asymptomatic aortic stenosis patients? Well, you see, what you can see here from this table is that a lot of this evidence is just a class level C, which means it's expert opinion. It's not really based on data. So it's indicated if left ventricular ejection fraction is less than 50% due to aortic stenosis. It's indicated if symptoms on exercise test due to aortic stenosis. It should be considered if blood pressure fall on an exercise test. It should be considered if none of the above, low surgical risk, and one of the following, a peak velocity of more than 5.5 meters per second, severe calcification, and a velocity progression of more than 0.3 meters per second per year. But all these ones are either class 1 recommendation, but always with a level C evidence. Always are these expert opinions. And it may be considered if none of the above and one of the following, an elevated BNP, more than 20 millimeters of mercury mean gradient increase with exercise, or an excessive left ventricular hypertrophy without hypertension. So clearly, I think from this slide is that we need more evidence. So should we then conduct a new trial? Well, actually at the moment we are developing it. Actually last week I presented to somebody, so a company who may sponsor this trial. So what we would do is then early surgery versus watchful waiting. Trial endpoint, what would it be? Survival, of course. We always like to have trials that have an endpoint that's just a survival. That's easy to interpret, and we all like to save patients' lives. So in asymptomatic patients, we have to realize that there is a weighted meta-analysis, 12 studies with almost 9,000 patients years, and then you can conclude that the risk of sudden death is about 0.85 per patient per year. And then the risk of death due to congestive heart failure is about 1% per patient per year. Combined, this would mean that there's a 1.5% per patient per year of risk of sudden death. But of course, we have to also take into account that we will have more endpoints because patients will also die during follow-up. And that depends on the SCS score, the risk that the patient has, and of course also the age of the patient. So you see that after, if you look at those patients, 70 to 79 years of age, does it work? Not on black, or 70 to 79 years of age. After, with an SCS score between 0 and 5, after 4-year follow-up, 83% are still alive. If you look at patients who are older than 80 years, only 75% are still alive. So there will be a lot of endpoints also just due to the normal death rate after surgery. Inclusion criteria would be, of course, patient with a certain age. You have to have a severe aortic stenosis, absence of symptoms, absence of subjective limitations of exercise capacity, or complaints expressed by the patient and confirmed by the cardiologist. And that's always the tricky thing. So what is exactly asymptomatic? And we have to define it very carefully in the protocol. And patients, of course, should be fit for surgery. Exclusion criteria should be class 1 or 2A indication for surgery, including atrial fibrillation and pulmonary hypertension, according to the guidelines. This exclusion, of course, are also when patients have symptoms, ejection fraction below 60%, atrial fibrillation, pulmonary hypertension, and physical inability to undergo surgery, and then signs of heart failure. As a combined endpoint, we could think of not only survival, because then we would need a huge number of patients, but also days alive out of the hospital. And that was, of course, also one of the endpoints in the partner study. So there has been some examples before. Surgery is, of course, at first behind watchful waiting, because you start operating a certain group of patients and they will be hospitalized. But, of course, a large number of these patients will also be operated during follow-up, and then you will also have the disease and the days in the hospital. Advantages of early surgery might potentially be a lower risk at the time of operation. These patients are in a healthier condition, they're younger, and they're more healthy, so perhaps less complications and less lengths of stay. Then there will be preservation of left ventricular ejection fraction, lower procedural risk again, and post-operative quality of life might also be better than those patients that have a severe symptomatic aortic stenosis. And perhaps due to less progression of the disease, less hospitalizations and less sudden death. So if we just look very briefly at the sample size calculation, if we do this, if we would take the primary endpoint at 4 years, we would roughly need a little bit more than 1,000 patients. So hopefully this trial will start this year, at the end of the year. For now, asymptomatic aortic stenosis patients, follow them very closely because a lot of them will become symptomatic. Surgery is needed now, as already indicated, if you have a low ejection fraction and where you are symptomatic on exercise. Then, treat when symptoms occur immediately. Don't wait too long. And then, perhaps we need much more data to really know whether we need to treat asymptomatic patients with surgery, yes or no. Thank you for your attention.